class. Okay, this is the second part of the lecture for today. I'm just gonna bring up my PowerPoint presentation so that you have it. Okay, so we've already done the getting to know you a little bit. You're gonna do the discussion thread, we reviewed the syllabus, general housekeeping. We already kind of talked about if there's something, I just want to reinforce this, that is triggering about this class. Could you just reach out and let me know? I don't need to know all the details or anything like that, but if for some reason we're in class at some point and you are kind of having a reaction, I like to know that you're okay and if I need to intervene in some way. So if there's something about this class that you've had, life goes on. This is one thing you'll hear me say over and over again throughout the semester, is that death never happens in a vacuum. And so, we've had people lose loved ones during class or pets during class, and it's just become very overwhelming sometimes, the topics. So feel free to just kind of reach out to me and let me know if you are concerned there could be a trigger, just so that I know if you get up and walk out of the classroom at any point or are not responding on a discussion thread, that I know what's going on so that I can keep that in mind. So, okay, we're going to talk a little bit about death in society. And here's the thing that's so interesting about death. Death is universal. Like, everyone is going to experience death at some point. Some of you probably come to this class and have had losses or a series of losses. Some of you might come to this class and you've never had any loss at all. And you think, oh my goodness, I don't know about this class because it's making me more anxious about having the possibility of losing someone. Here's the thing, is that we are all going to experience loss at some point, in some form, at some time. So it's something that we tend to avoid as society. We tend to avoid wanting to talk about this. And so real important that we as social workers sort of create an open space for people to be able to talk about their experiences, talk about these losses, because interestingly, oftentimes I have folks come into my private practice and maybe they've been diagnosed with depression or they've been diagnosed with anxiety, and they come in to start doing counseling, and very quickly I do a loss history and realize that this person has had numerous losses in a very short amount of time. And so they're not so much dealing with depression as they're dealing with complicated grief reactions. And so the treatment for that is very different in that we want to kind of process that grief and process that loss, which is very different than just sort of managing depression or anxiety. So many of you might be very familiar with when we switched to the DSM-5. It used to be that in the DSM-4 TR, that a person who had experienced a loss within the last 6 months could not be diagnosed with major depressive disorder because in the presence of a loss, it was thought that those symptoms are most likely part of the grieving process. One of the biggest controversies when we switched to the DSM-5 was that it took that caveat off, that qualifier off. And so now someone who has experienced a loss and is having symptoms that would mimic depression, but just going through the grieving process, can be diagnosed with a major depressive disorder within 2 weeks of that loss, which is really very controversial, because on the one side, that helps people get access to medication and things that they might need. But are we, and this is sort of a philosophical question, are we making something that is a very normal process, grief, pathological? So that is of concern, right? How many of you would expect that if you lost a major attachment, that within 2 weeks your symptoms would resolve and you would no longer be feeling sad or thinking about that person all the time, or fatigued, or actually feeling physical pain from the grief of losing someone? Probably not, right? 2 weeks, major attachment. That seems like that wouldn't um, reasonable. How many of you would think that 6 months would be enough? After 6 months, you should be over it, right? No, that's just not the way it is. So, and when we look at all of the research and the theories on grief, we realize that grief never ends. And that's sort of liberating for some and daunting for others, right? Is that grief never ends, is that we never get over grief. There will be times when it's less intense, and there will be times when it's more intense. And so, I use my family as sort of, they're like a little petri dish for me, and explaining a lot of these things and examples. But I think about my dad, who lost his dad when he was 12, and when he was 45, had a period of intense grief where he just missed his dad so very much, and would cry a lot, and had some sort of episodic moments of just intense grief. Does that mean that he had complicated grief, or that he had depression or anything like that? No, he just, at that period in time, really just missed his dad. And then he continued to function, which of course is the key. He was able to continue to function, and then it sort of subsided. And then he has times, of course, that he misses him, but and sort of experiencing that grief. But most of the time is, kind of just very functioning and doing what he needs to do. So, so all of that to say that grief never just resolves, never just heals completely. There are always times when we swing back into intense grief responses, and that's not considered outside of the norm. The other thing I would just say is that within loss, when we are talking about grief, the line for what normal, quote unquote, looks like really is very blurred. There are folks that will come in and tell me that they want to die because they just can't go on without that person. Well, if that was in the absence of grief and someone tells me that they want to die, then that's going to put a red flag up, and then I'm going to need to evaluate their safety, and probably not have a huge tolerance for that kind of talk before I have them hospitalized, right? Because we want to make sure that people are safe. But in the presence of grief, unless, of course, there's a history of suicide attempts or things like that. If that's not the case, then I'm going to have a pretty high tolerance, and I'm not going to take someone who's grieving, who tells me that they just want to die, they feel like they can't go on, and an emergency petition them to the hospital, right? I'm going to explore that more, make sure there's not a history, and then, sort of just universalize that and normalize the fact that many people, after they experience a loss, feel that exact same way, and will say those exact same words, that they don't think they can go on and they'd rather be dead. So, of course, we do our due diligence to assess, make sure someone is safe. But after that's done, that really is very normal for someone who's grieving. I've had people who come in and say, every morning I make breakfast for my spouse who died 5 months ago, and I still make breakfast, and I still sit there with them. Again, this is not going to raise the flag on psychotic symptoms in some way. In the presence of grief, I'm going to be much more tolerant of a lot of those symptoms, because everyone grieves in a very different way. So some people never experience any of those things. Some people do. And none of that, again, after a thorough assessment of sort of past mental health issues, none of that's going to make me really very concerned. Everybody is so very individualized in that. And I think the boundary at which point red flags would go up for psychotic symptoms, for suicidal ideation, a lot of those things are very normal in this grieving process, and really not pathological if they come in and we can kind of work through that grieving process and normalize a lot of that. You see people who just walk through the process for however long it is, because everybody's so very different in the time frame. Oftentimes I get the question, well, what is the time frame? I would say that certainly 6 months is not it. Oftentimes we think about a year to 2 years. If people are still intensely grieving at the 2-year mark, then we're going to start thinking about some complicated grief that certainly could be popping up for someone. Okay. Oops. So what factors really impact one's experience of grief? And so let's just talk a little bit about that. The first one is the nature of the relationship. So oftentimes we think about relationships, you know, and are they tumultuous relationships? Sometimes that can lead to more complications in the grieving process. You know, we hear these horrible, horrible stories about someone getting in an argument with their spouse and their spouse leaves, gets in a car accident and dies. And their last words to that person were, you know, I don't want a divorce, or I hate you. Those things sort of set the stage for possible complicated grief. I've worked with folks who had been having an affair prior to being diagnosed with a devastating diagnosis, and then sort of cut that affair off to help their spouse through treatment and eventually through hospice, and they died. And the complications from that, just that extramarital affair, things like that going on in the relationship. Again, death never happens in a vacuum, right? So things like this are going on all the time, and they complicate the grieving process oftentimes. Sometimes, and we need to be careful on the flip side of this, is that sometimes people don't grieve as intensely as we think they maybe should, right? Or we would expect, because the nature of the relationship is that, you know, this person was abusive to them, and when they died, they were happy about it, right? And it sounds harsh, but it is very true, that we need to look at the nature of that relationship, is that not everybody who loses a dad or loses a mom or grandparent is going to be grieving the same way because of the nature of the relationship, what was going on in that relationship. Certainly a history of prior losses also can impact how people are walking through the grieving process. If people have a string of significant losses in a very short amount of time, we'll oftentimes see complicated grief. And we're going to talk about what complicated grief looks like versus normative grief. But oftentimes you'll see that if there's a history of prior losses. The other piece of this that I just want to kind of bring to your attention is that when we experience a loss in the present, if we have experienced loss previously, no matter where it was in our lives, oftentimes those emotional, it's almost like an emotional trigger that will trigger emotions from that prior loss. And so it is thought, when you look at the research, that when you experience a loss in the present, you actually re-experience all of the losses that you've had previously. And I think it's just because of the intense emotional reaction that is so very similar. And so it kind of brings up those losses again, and people sort of have to walk through the process of grieving not only the present loss, but in some ways, and maybe very less intense, the losses they've experienced in the past as well. So age is another factor. This is an important one, and one to keep in mind when we start thinking about what not to say to folks when they experience a loss, no matter what the age of the person that has died. Because we, in our society, think that it is very abnormal for us to lose a child, right? Children shouldn't die at a young age. But yet, if someone lives to be 90, we oftentimes will say, oh, well, they lived a good life. And in some way, feel like that is okay that they died at 90. So we want to be really careful about that because it's very culturally driven. When we look at the Elizabethan era, they used to have 8 children and name them all the same name because they knew that there was a good chance that only 2 would actually live to be adults, right? So the expectation back in that time was that children do die, and that we should have as many children as possible because they're not, that there's a good chance that some or many of them may die. So that's a very different culture shift, and with medical science, how that has kind of dictated the change in our cultural sort of norm, what we think is norm. So important to just keep that in mind. Things that we would not want to say, and we'll talk more about this when we talk about children and grief, but well, you can always have another child, right? Not helpful. Could possibly get you punched in the face. Not helpful at all for anyone. Keeping that in mind, not something you'd want to say. The other thing is that as oftentimes we talk about elderly folks who have died, we have to be careful because the nature of that relationship, that relationship of a grandmother might have been closer than a parent. A mom or a dad. And so to say, oh, well, at least she lived a full life, or at least he was, he made it till he was 90. That is not going to be helpful either, because when someone's grieving, they're not thinking about that. They're thinking about, well, I wish that they had made it to 91. And I loved this person and they're not here. So saying things like that, and, we may even have found ourselves saying, oh, at least they had a full life, or things like that, not really helpful to someone who's grieving. Okay. Religion oftentimes impacts how people experience the grieving process. As you can imagine, right? Certain religions believe in an afterlife, certain believe in reincarnation. So it very much impacts how people feel when they're thinking about what happens now that their loved one is gone. Do they believe that they're coming back and they may see them again? Do they believe in some sort of heaven that they will be reunited with them at some point in time? And so that can very much impact how people view death and sort of the whole process. Now, here's the interesting thing about religion is that, and spirituality, religion more so, is that religion can be an immense support for people, positive support for people as they're walking through the grieving process. And on the flip side of that, it also can be a tremendous barrier to people as they're going through the process. So we have to really assess, is religion a positive support or not? And what kind of worldview do they have that might impact if religion is helpful to them or not. I've worked with folks who have died from a stigmatized death, something like HIV or suicide, or an abortion, things like that. And religion has, or the person has been left feeling more condemned by their religion, and therefore it has complicated their grieving process, as opposed to when people find religion to be a very positive support for them, where they can sort of just lean in and have the support. I often tell the story about working with a woman who had ALS, and she was Unitarian, and when she was diagnosed with ALS, the day she went to the clinic and was diagnosed, her husband of like 15, 20 years said, nope, can't walk through this process with you, packed up and left. Left her with 2 little children, and ALS. So she, when I came on the scene, it was like maybe 8 years later, she was on a ventilator. The Unitarian church that she had attended had provided around the clock 24-hour care from their community and their congregation for like 5 years. So they came together, and she was never alone with her children. There was always someone that had been trained to suction and do all of her care, all of her needs, so her children didn't have to do that. There was always someone there for 5 years, 24/7. Incredible source of support, not what everybody gets. So we just have to kind of assess where religion falls for people. And then one's larger worldview is really important as well. Is just how do people conceptualize why things happen the way they do? And this is a really important piece because, everybody sort of has their own conceptualization of how the world runs. When I first started working in oncology, I remember I was sick for like 6 months straight. And I was angry because I was seeing parents come in, moms come in who had 6-month-old babies who were diagnosed with cancer and would be dead within a year. And you're thinking this little kid's never even going to remember their mother. And, and I was angry about it because in my own worldview, crappy things like that shouldn't happen. And so I had to come to a place where I sort of readjusted my worldview to understand that these sort of traumatic things do happen, and that along the way there are very small miracles that as a social worker we get to witness. So we may not be able to see someone go into remission and be able to live out their life for the next 20 years, but we may be able to help them build a memory box, or we may be able to help them in couples counseling deal with what this is going to look like and still feel like they're part of the parenting process, and all of those things, leave a legacy. And those are the small miracles as opposed to the remission. And so I had to be able to change my worldview. And once I did that, I was able to really embrace and enjoy this kind of work. But it's a process for everyone that we have to sort of look at how we understand why the world is the way it is, why things happen the way they do. And it's very individualistic. Another piece of the grieving process and people's experience is this idea of culture, right? Is that our culture very much dictates, and cultural and social learning kind of go together here with this, is that it really dictates how we respond to loss, right? Some cultures, when someone dies, they hire wailers, and it is okay if you're not wailing and falling on the floor, then it's thought that something is wrong with you, right? Not so much in other cultures, right? In my staunch German culture, there's, if I'm hospitalized, then someone might call and be like, hey, let me know when you get out, right? As opposed to other cultures, some African-American cultures that, they'll have a prayer vigil in the hospital with 60 people, a whole congregation will come in. So it's very culturally and religiously and social conditioning driven, right? Is what is acceptable behavior in response to a loss is very much driven by our culture and our social conditioning as seeing how this is done within our culture. Okay, hopefully that makes sense. When we get to talking about Worden and the task theory, we're going to talk so much more about the mediators and things that really impact the grieving process. But for now, we're just going to look at these. So let's just talk just a tiny bit. We are a culture that doesn't like to talk about death. We try to avoid death. I mean, just look at the commercials that are on for all of these potions and things to keep us young. We don't like to put death out in the open. We like to sort of sweep that under the rug and not talk about it not address that this is something that we all will experience. We like to keep illness and death out of sight. We like to attempt to avoid getting older at all costs, or sick, that kind of thing. So this is very true in the medical community as well. So I just want to touch down on that is that there's a culture in the medical community of curing, right? And thank goodness, right? We go into the hospital, we want to be cured, or we see our doctor, we want to be cured. But when that is not possible, oftentimes that's seen as defeat. And so we have a lot of trouble sort of transitioning our paradigm from a curative to a palliative model of care. And so there's been great movement in that. Some of you probably work in a palliative unit now or hospice, but there's been a huge pushback to that. Because doctors are trained to try to cure, not to just provide support and allow the natural processes to happen. So it is very challenging, even in our medical community, to talk about death. If you've worked in acute care before, you know that oftentimes physicians, they don't want to talk about hospice. They don't want to talk about options that don't relate to continued treatment for curing. They want to keep talking about that. And oftentimes patients then don't have an array of options of what they really want. And we see patients who may say, hey, you know what, I don't want curative treatment. Like, I've lived a full life. I don't want to go through chemo. And we say, oh, something must be wrong with them, because they don't want to go through that process, as opposed to supporting them and saying, okay, well, you get to make that decision. And you get to choose if you want to have treatment or not. So we're very uncomfortable with that. Okay, we're going to shift gears, and this will be the last thing that we kind of talk about today. But to talk just a little bit about death anxiety. So some of you may have signed up for this class and sort of just had like this little spike of, ooh, I don't know if I want to talk about death. I'm not sure if I can handle this class. Like, I'm really uncomfortable. And that kind of thing. That's normal, right? It's a phenomenon that we know exists, and it's called death anxiety. And that's when we're just really uncomfortable. We get distressed and feel sort of this apprehension when we even think about death or losing someone. When we look at sort of the whole lifespan, we realize that there are times in that lifespan where we all, universally, it sounds a little existential, doesn't it? We all sort of have an increased spike in death anxiety. So when we look at this, when we look at age and gender and past experience, certainly past experience can impact people's level of death anxiety. So for example, if you have ever been around someone who has been sick and you thought, oh, they're just have a cold or something, and then something bigger happened and they were diagnosed with some devastating diagnosis, it's less likely that next time someone has a cold, they'll just be like, oh, it's nothing, right? You're going to be a little bit more sensitive to that. For example, my dad, he had 3 heart attacks, and when he before he went to the hospital, he said, I think I'm just getting a cold, and my left arm is hurting a lot. But I was chopping wood. So he had a lot of denial going on. And we were all like, oh, that could be. And then finally, when we started putting it all together, said, no, I think you need to go to the hospital. And he had 3 heart attacks before he even got there. So you better believe that when someone's like, oh, I feel like I just have a cold and my arm is hurting, our family, for not so much now, but for quite a few years, we're like, oh, you better go get evaluated, right? Because we had an experience where we had denied, and then all of a sudden it was much bigger than we thought it was. And so when we have a past experience like that, we tend to be a little bit more hypervigilant, if you will. And again, that wears off too. Now we're right back to denial, so don't worry. But that is kind of the process. Okay, so looking at ages, think about it for a moment. who do you think probably experiences more death anxiety? Is it males or is it females? Think about that for a moment. So some of you probably said males because because of their role. Lots of folks have sort of like the typical male role of, providing for a family or being in the business world and things like that. Some of the more traditional roles. Some folks may have said that. Some may have said because males don't talk about their emotions as much, but that they probably have a lot of anxiety about death. So that's some of the answers I usually get. I don't know how many of you thought females, and maybe because females tend to talk more about and maybe even emote more, right? We're drawing really, really broad lines here. But so thinking about all of that, I'll give you the answer. The answer is that females have more death anxiety. On the whole, females tend to have more death anxiety. And the reason from the research that they believe that to be true is because females have very set biological and physiological markers to show when they are getting older, right? So females begin to menstruate, and then when they hit menopause, they stop menstruating. And so it's like that sort of part of their life is over, childbearing years is over. And so there are very clear physiological markers in females of getting older. And so that appears to be correlated with higher death anxiety. Okay. So if you're surprised by that, okay, I gotcha. Age. So there are two distinct time periods when people experience death anxiety. So maybe your first instinct is, oh, when the older population. That is true. There is it's kind of like the proximity idea that when you're around lots of folks who are dying, and when people are getting older and their friends are dying, and that kind of is happening, then there can be more death anxiety. There's also a spike in death anxiety, interestingly enough, in early adulthood. So for many of you, if you're experiencing a period of death anxiety right now, not surprising, especially because you're finishing a master's degree. What they're kind of figuring out in the research is that that young adults sort of get to this point where they're like, the world is my oyster. I finished my education. I'm going to get a good job. I'm going to buy a house. I'm going to go travel. I'm going to, start a family. I'm going to be independent and tour Europe, like whatever it is, that there's like this idea that, oh my goodness, here are all the things that I want to do. What if I don't get to do them? What if something happens and stops me on my path? And so there's a spike in death anxiety in early adulthood, and then again in later adulthood. Okay, so hopefully that makes sense. I'm going to stop here, and we're going to come back to this next week. Hopefully this is helpful. I know it's not in the classroom and I don't get to hear your questions, but if you do have questions about any of this, please don't hesitate to text me or post a message in that questions thread on Blackboard, and I'll be happy to respond to it there. All right, here's to seeing you next week, and hope all is well and you have a great week. Take care.